welcome to today's HPL seminar. Thank you for joining us. Before I kick off today's seminar, I just want to take a moment to recognize some progress we've made this term. So since I started hosting the seminars, one of my goals was to bring a diverse lineup of speakers from different lab groups. And I'm happy to share that in just 7 weeks of presentations, we've had presenters from 6 different lab groups, and I'm really excited to share that. And it's been great to see such a range of research and projects presented here, and I would like to encourage people that have not presented in the past few years to come and sign up. We still have some spots left over for the rest of the term at the end in June, and so I'd be happy to sign you up for those presentations. Today, it is my pleasure to introduce our speaker, Nathan Boon. Nathan has a diverse background in both clinical and research settings, bringing a very unique perspective to the study of human performance. He started by earning his Bachelor of Science in Kinesiology from the University of Waterloo in 2012, and then he later pursued his Doctor of Chiropractic at the Canadian Memorial Chiropractic College in 2021. Now he is a resident with the Royal College of Chiropractic Sports Sciences Canada, and also a master's student here at the University of Calgary, and he is supervised by both Dr. Matt Jordan and Dr. Walter Herzog. Outside of the lab and clinic, he enjoys to cook, hike, camp, and watch comedy. And if you ever need advice on your fantasy sports lineups, he proudly considers himself, and I had to Google this word on how to pronounce this, but an aficionado in that domain. Today, he will be presenting his insights from his research on repeated hopping and plyometric performance in ACL injured athletes.
Thank you very much. Everyone here? Yeah, perfect. So when I was 18 years old, I hurt my knee in a basketball tournament. And a couple weeks later, I was sitting in the office of a sports medicine physician, and I could tell that her demeanor changed as soon as she told me that I had suffered an ACL tear. And so at the time, I didn't really know what this was. I had never heard of an ACL before I was 18 years old. But I could tell that this was something big. And what I told my coach a couple of days later, he referred to this as a death sentence for an athlete. And so in retrospect, that even to this day seems a little melodramatic. I'm starting to now kind of, through all my research, start to understand what it was that he meant by that. So when I look at the ACL landscape and the ACL literature, I see 3 main problems. So the first one is that there's lots of ACL injuries. So there's a 2.8% pool incidence of ACL injuries across all athletes, which means about 1 in 36 athletes are likely to undergo an ACL injury.
Is it Michael?
Are likely to undergo an ACL
He's
injury.
wrong.
Is that better? Oh, that's much better. Okay. So one in 36 athletes are likely to undergo an ACL injury at some point in their athletic career. The second major problem is that these athletes, once they have their injury and they undergo an ACL reconstruction surgery, which is the most common way that we sort of manage these cases, only 65% of these athletes will actually return to their pre-injury level of sport. And if that is a competitive sport but non-professional, that number actually drops down to 55%. Okay. And so then the third major problem with ACLs is that if athletes do manage to return to their field of play, they're at 40 times increased likelihood of suffering another ACL injury compared to their uninjured counterparts. So our group with Dr. Matt Jordan, we're specifically kind of interested in this problem, right? How are we rehabilitating these athletes after these surgeries? How are we monitoring their progression, and how are we sort of getting them back onto the field of play? So I wanted to take a moment to actually talk about ACL reconstruction itself, because I feel like probably a lot of people are sort of in the dark about this. They hear these words a lot, but they don't really understand what happens. So the anterior cruciate ligament is a passive stabilizer of the knee, and it restricts anterior tibial translation. So anterior translation of the tibia relative to the femur. And so if we tear this, we now have what we would call an unstable knee. So a surgeon will harvest a graft from a donor site. And so the 3 most common sites are the quadriceps tendon, which is above our patella, the patellar tendon, which is below the patella, and our semitendinosus or gracilis tendons, which is sort of on the posteromedial side of the knee. And they'll sort of, fashion this into a new ACL, slide it through a couple tunnels in the knee, and that sort of is supposed to sort of give you back that stability in that knee. So there's three, again, main problems with this approach. The first is that this is a graft and it's not a native ACL. So although these grafts go through a process that we call ligamentization, which implies that over a period of time, they begin to adopt some of the energetic and histological properties of an ACL. They never really regain the full tensile strength of these native ACLs. The second problem is the same. It's not a native ACL. So an ACL does a lot more than just provide stability in the knee. It's also a very powerful proprioceptive organ in our knee joint. So when we replace it with an uninnervated graft tissue from somewhere else, we now don't really have that same proprioceptive feedback that we used to have when our knee was intact. And then the final problem with this is obviously we are disrupting a lot of the active components that we use to actively stabilize the knee. And so this leads to a lot of the long-term deficits in strength and performance that we see in these athletes, 2, 5 years later, even the rest of their life potentially. So after someone undergoes one of these ACL reconstructions, they'll typically progress through a multi-phase rehabilitation protocol. And that usually culminates in some kind of return to sport testing day in which they're put through a battery of tests and they either pass or fail these tests. And if they pass the tests, then they're cleared to return to sport and they're an athlete again. Okay. But this approach is starting to fall out of favor somewhat in favor of what we refer to as a milestone-based or monitoring-based approach, in which we routinely test and routinely monitor these athletes throughout this entire rehabilitation process, even beyond our return to sport. So we can kind of understand how they're progressing and in what domains they are progressing or not progressing. And so this means that at each testing component, we can say, okay, you're getting better at this. We can start working on something else and sort of start to tailor a rehab sort of as you go. So if you were a clinician and you were thinking about how would I do this, intuitively you would say, well, at different time points, I would want to sort of test different things. But really, ultimately, I'm interested in how someone improves in multiple different characteristics of athletic performance over the course of this entire time frame. So practitioners usually conceptualize athletic performance across a continuum of contraction velocities, with slow contractions being like our isometric movements, and we can move faster and faster and faster, with generally with lower and lower loads. And so the important thing about this is that this allows us to sort of profile an athlete and understand where their strengths and their weaknesses lie. But more importantly, each of these specific qualities require different training techniques, right? So if someone's really good at one thing and bad at the other thing, we want to sort of tailor how you train to address that one quality. So not only do we want to be now assessing these athletes across a number of qualities, but we want these tests for this ACL injured population to sort of check a few key components. So the first is that we want these tests to be sensitive to the deficits associated with an ACL reconstruction. So obviously, if I'm testing an ACL reconstructed athlete and a healthy athlete, I want to be able to actually pick up deficits in that injured athlete that I wouldn't see in the control athlete. I also want these tests and the metrics that I choose to be relevant to sport performance as well as return to sport success, preferably using metrics and tests that are validated prospectively in the literature. We want our tests to be feasible to implement, especially in practical settings, right? So these shouldn't be expensive, they shouldn't be time consuming, they should require lots of coaching. And we want our tests to be reliable so that true changes that we measure over time are actually reflective of true physiological changes in our athletes. So the most common assessment of ACL reconstructed athletes function is a single leg hop for distance, in which an individual does a single leg hop for distance. And so what we measure is the distance that they jumped, so usually on that injured leg, and then we'll compare that to how far they can jump on the uninjured leg. And then we can say, oh, your injured leg is 80% that of your uninjured leg. There's a big problem with this in that recently it's been shown that the knee joint actually contributes a relatively low percentage to the total mechanical work performed during the propulsive phase of this movement. And so this means that the distance that we measure is actually not really reflective of what's going on at the knee joint or what's going on at the level of the knee extensors, okay? Especially when we compare that to a vertical jump. In fact, ACL injured athletes have been shown to, potentially exhibit near perfect symmetry in their single leg hop distance, but still have significant asymmetries in their single leg hop height. So instead, a lot of practitioners are relying on the drop jump, in which someone drops off a box onto some force plates and jumps back up. And so this obviously satisfies that vertical jump criteria, but it's also an evaluation of an athlete's stretch shortening cycle capacity, how they can kind of manage this eccentric concentric loading. And so deficits in this stretch shortening cycle capacity have actually been shown to predict future second ACL injuries following a return to sport. And so this for sure is something that we want to be measuring in these athletes. And so metrics associated with stretch shortening cycle capacity are things like center of mass stiffness, changes in joint flexions, ground contact times, and something called the reactive strength index. And so our reactive strength index is our ratio of jump height and ground contact time. So how high did you jump and how long did it take you to sort of generate the impulse required to jump that high? So you can imagine if you have two athletes performing this test and they both jump 40 centimeters, but one takes 400 milliseconds to do that and one takes 200 milliseconds to do that. If you're building a volleyball team, you'd rather the guy that can jump 40 centimeters in 200 milliseconds. So although it seems like a great test, there are a number of key sort of issues with actually implementing it. And so the first, very obviously, is how high should the box be, right? Is it a 15 centimeter box? Is it a 30 centimeter box? Is it half the height of my leg? Is it, should it be my maximal jump height? Should my box height be the same as your box height? As I get stronger, should my box height change? Right? You can see there's lots of different sort of conceptual issues with how we even just select something as simple as box height. But the other major issue with this test is that if we're interested in jump height, that means we need to calculate takeoff velocity. And if we want takeoff velocity, that means we need to understand what the athlete's landing velocity is. But what's been shown is that often when athletes step off the box, they'll kind of lower themselves down a little bit first, which means we can no longer use the box height to determine landing velocity. And so we can get around this a little bit by if we have a force plate on the box and then one on the floor. But again, now we're starting to get away from sort of practical settings where, in most gyms or clinics, they can't really set up that sort of situation. And so this is where the repeated hop test comes in. And so this obviously looks very similar to our drop jump test. It's a vertical stretch shortening cycle test. It's been used for decades to sort of model and understand how humans regulate things like stiffness and lower limb activity and energetics. And so more recently, it's been used a little bit in the ACL reconstructed sort of injury world, but there's not a whole lot of evidence supporting its use in this population. Although there does seem to be some indication that this test is sensitive in detecting these stretch shortening cycle deficits in these athletes. However, when we think about, again, how do we implement this test, there's still a number of questions. Right? Like how many hops do we do? If we do 20 hops, should we look at all the hops or just 5 of the hops? Should we do single leg or double leg hops? How should we instruct this test, right? So there's still many sort of interesting questions about how we actually implement the test that still need to be answered. And so one key feature of this hop test is if you have people, uninjured people, hopping at relatively low intensity, so this could be high frequency hopping or hopping to minimize ground contact time or hopping to keep forces relatively low. We see that a lot of the modulation and how they regulate stiffness and performance is done above the ankle joint. But as hopping intensity increases, so lower frequency hopping, higher height hopping, higher force hopping, we see a larger relative increase in demand placed on our knee joints. And so right away, you can see that this is kind of an interesting model for studying how ACL injured athletes with injuries at their knee joint might sort of regulate stiffness and performance in these two separate conditions. And so this brings us to our question today is, how should we optimally cue the repeated hop test in order to evaluate function in our ACL reconstructed athletes? And so I wanted to look at two separate cueing conditions. The first was I told athletes to hop as fast as you possibly can, like you're trying to minimize your ground contact time. Right, so this is akin to our high frequency, low intensity, kind of more ankle dominant hopping style. We're going to refer to this as our hop fast condition. And then the second cueing condition was to hop as high and as fast as we possibly can. And so here, this is our more kind of low frequency hopping, higher intensity hopping. We're going to refer to this as our hop high condition. So it had two primary hypotheses. The first is that our hop high cue will display larger knee flexion angles as well as greater levels of total muscle activation compared to our hop fast cue. And then our ACL limbs will demonstrate reduced performance in our hop high condition compared with our uninjured and our healthy control athletes that we're going to compare to. So we managed to recruit 28 athletes, 15 of which with ACL reconstructions. The average age of that ACLR group is just under 20 years old, with an almost even split between males and females. The average number of months post ACL reconstruction was 10.62. And the reason why this is significant is because this is kind of right in that sweet spot of where many athletes sort of begin to consider returning to sport. Most athletes get back to sport kind of between 9 and 12 months after the surgery. We also had an almost even split in our graft type. And so we only included athletes that had either a bone patellar bone graft or a quadriceps tendon graft, which, if you can remember, are the two grafts that sort of make up the anterior chain or the knee extensor mechanism. So we had our athletes perform a maximal isometric knee extension test in our custom-built isometric dynamometer at a knee angle of 80 degrees with 1,000 hertz sample frequency. We also performed a standing single leg plantar flexion test using our AMTI force plates, and this is primarily used just to sort of normalize our muscle activity. For a repeated hop test, athletes performed hopping on both the left and the right limb under both sets of cueing instructions. And so we used a dual force plate system from AMTI that samples at 1500 hertz. We also collected surface EMG from the vastus lateralis, vastus medialis, lateral gastroc, and soleus muscle groups. And then what we did is we averaged our vastus lateralis and vastus medialis muscle activity to give us a quadriceps muscle activity, and our lateral gastroc and our soleus to give us a triceps surae muscle activity. We also use IMUs on the pelvis, thigh, shank, and foot, so we can get relative knee joint angle, relative joint angles throughout the test, and these are sampled at 200 hertz. And so I just wanted to give a bit of visuals to sort of kind of what this looks like, just so everyone's sort of on the same page. So on the left, we have someone here hopping as fast as they can. They're trying to minimize their ground contact time. You can see these black straps are our IMUs, and we have our surface EMGs sort of taped down. Everything's wireless and synced through our Neuraxin program. On our right side here, we have the same individual hopping under the condition, hop as high and as quickly as you can. And so you can see right away that these two conditions are very different, and we can likely expect to see some differences between the two conditions. So one interesting problem that we also ran into is how do we calculate hop height? So similar with the drop jump, in order to get hop height, we need takeoff velocity. In order to get takeoff velocity, we need landing velocity. So most people will use the sort of total flight phase to determine the jump height of the previous hop, and then use that to calculate landing velocity. However, we know that athletes tend to jump and land sort of in two slightly different configurations. And because we land in a slightly flexed posture, we actually land from a higher height than we jumped to, if you can imagine that. So what we did is, with the first counter movement jump of that test, we can take our takeoff velocity, and then we can break that subsequent flight phase into kind of a rising time, and we sort of know where the peak is based on our takeoff velocity, and then the rest of our flight phase we can sort of refer to as our falling time. And so from that, we can calculate a landing velocity, and then we can integrate our acceleration signal over the ground contact time and get our takeoff velocity for the next hop, and sort of do this through subsequent hops. Through this method, we can also then divide our ground contact phase into a landing phase as well as a propulsive phase, which is sort of in line with a lot of other sort of kinetic approaches to evaluating human movement, like counter movement jumps. For our statistical methods, we use a statistical parametric mapping approach for our continuous time series data. And so what SPM allows us to do is identify regions of significance. So we can say, there's a significant difference between these two time series curves in this region, rather than performing statistical tests at each individual time point, which opens us up to a lot of errors. And then we also use a linear mixed effects model for all of our discrete outcomes, with limb status and its three factors, so injured, uninjured, and control. and the different cueing conditions and their interactions as our fixed effects, and then athletes were included as random effects in our models. So looking at some results, first we're going to start with our knee joint angles. So we're going to look at across each of our 3 limb statuses. On our y-axis, we have our joint angle, and our x-axis is our normalized ground contact time. So from 0 to 100%. So our red curve is the hop high condition, and our blue curve is the hop fast condition. Okay? So the gray block indicates the regions of significant difference between these 2 curves. So you can see that our hop high condition is generating sort of much larger knee flexion angles, especially kind of in that mid phase of our normalized ground contact phase. For our quadriceps surface EMG, again, this is the average of our vastus lateralis and vastus medialis surface EMG. We integrated our signals over 3 key periods or 3 key phases of our hop cycle. So we have a pre-landing phase, which is the sort of last 50% of the flight time. We have our landing phase, and then we have that propulsive phase. And so right away, we can see that there's no significant differences between any of the limbs within the cues and within the different phases. So each limb is sort of exhibiting the same sort of total muscle activation pattern as all the other limbs. Although we are seeing significant differences and significant increases in our total muscle activation in our hop high condition compared to our hop fast condition, only in the landing and propulsive phases. For our triceps surae activation, which again is the average of our normalized lateral gastroc and soleus, again, we're seeing no significant differences between our limbs, but again, large increases in our total triceps surae activation in our hop high condition versus our hop fast condition. So based on this, these results sort of confirm our initial hypothesis in that our hop high condition will have larger knee flexion angles and generally larger total muscle activation angles, or muscle activation. So with regards to hopping performance, the 5 key metrics we are interested in, clinicians and practitioners generally are interested in, are jump height measured in centimeters, our contact time, our reactive strength index, which again is that ratio of how high did you jump and how long did it take for you to jump, our body mass normalized stiffness, and then our peak negative displacement, or how much do you compress during that landing phase or during that ground contact phase. And so looking at our high condition first, we can see that our non-injured and our control limbs jumped significantly higher, had significantly higher reactive strength index values, as well as increased negative displacement compared to our injured limbs. Whereas when we look at our hop fast condition, we see no significant differences between any of these limbs, although all these values differ significantly from that of the hop high condition. And so if we kind of start to put some of the pieces together, we have this hop high test, which the knee is doing more work. There's a little bit more muscle activity. We're getting higher jump heights, but these knee injured athletes are not really keeping up in performance with either their uninjured limb or their uninjured counterparts, with their control athletes. However, this difference is kind of washed away when we perform our hop fast condition, and it's more of a sort of an angle dominant testing type movement. And so what we're interested in doing is sort of explaining why this might be, and to look at some of the determinants of hopping performance. And so the main determinants of concentric muscle performance are the mechanical muscle function, and then your sort of neurological control of these muscles. And so we already saw that there's no significant difference between any of our limbs in terms of the muscle activity that we measured. But so then we looked at how does our hopping performance compare to just an individual's total knee extension torque. So on our y-axis, we have our reactive strength index, and on our x-axis, we have peak knee extension torque, again measured at 80 degrees. And we begin to see a moderate relationship between the strength of someone's knee extensors and their hopping performance. But again, this relationship only really applies in this hop high condition. Right, so unsurprisingly, when you're hopping for fast, and again, we're conceptualizing this as more of an ankle dominant movement, how strong your knee extensors are don't really contribute to your total hopping performance. And so there's three main conclusions that we can take from this. So the first is that different cues equal different movements and different activation patterns. And although this is kind of implicit, it's an important reminder, I think, for clinicians and practitioners that the way you instruct a movement will vastly create different movement outcomes by the person in front of you. And so if we think of dynamic systems theory, which suggests that human movement is this kind of emergent quality from this complex interaction between environmental constraints and individuals' constraints and the task constraints, we can begin to understand that, maybe we can manipulate these task constraints to sort of tease apart an individual's differences from other people. The second main conclusion is that the repeated hop test does appear to be sensitive to detect these ACL reconstructive related deficits, but the constraint really matters, right? So again, we need to be using tests that address the knee joint specifically, again, with this knee injured population. And finally, hop performance appears to be at least moderately determined by mechanical muscle function of our knee extensors. And so why, again, this is interesting and important for this population is that knee extension strength, knee extension rate of force development. These are deficits that we see in this population for a long time. And so we want to make sure that we are not only addressing our knee extension, but everything that sort of might go along with that in our rehab and return to sport. So as far as next steps, I mean, you can imagine that there are a number of sort of interesting directions that we can take the results from this study. One of the first directions I think would be interesting is to begin to compare our repeated hop test performance with our drop jump performance, again, specifically in this ACL reconstructed athlete. So we want to know if, performing these two tests are identical, or if maybe one gives us more information or different information. We can start to understand how and why we should implement it differently in our monitoring during a rehabilitation. The second next step that we could take this is monitoring the trajectory of our performance in this repeated hop test over an ACL rehabilitation. So how does an individual improve at this test? And how does that trajectory match the trajectory of improvements in things like knee extension torque, counter movement jump height, whatever physical quality you want. And then the last kind of interesting but different direction is sort of using the same fast versus high, but instead of looking at knee injuries, we look at ankle injuries, right? So does this same sort of pattern unfold if we look at ankle injured athletes as opposed to knee injured athletes? And again, we can begin to inform how our test constraints impact performance, and how should we consider modifying our tests based on the individual in front of us. So I want to thank my supervisors, Dr. Matt Jordan and Walter Herzog, as well as my committee, and then the entire INSPL group, as well as the Herzog group, and everyone that has contributed and supported me in my work so far. Thank you very much.
And how do you measure displacement?
Yeah, so displacement is measured from double integration of the acceleration curve. And so we can just take peak displacement from double integration of the acceleration curve.
And when you do this rehabilitation, after rehabilitation, you usually take images that denote the condition of ACL or?
So usually not. That's more a function of resources. And so if you are a professional athlete and you have unlimited resources, you will almost certainly be getting follow-up imaging probably for the remainder of your career. In the public health system, especially in Canada, that would be considered not an efficient use of time and resources.
Your horizontal hopping, you said that it's not sensitive to the distance. And is that only the distance, or you don't know that what's going on with the ACL, the pressure that ACL is tolerating?
Yeah, so that's a good question too. So I mean, you can imagine if you are a physiotherapist or you run a gym or something, you have limited access to equipment, this is a great looking test, right? It's simple, it's easy to run, I can measure the distance. The interesting thing about this paper is that the next image in the paper is about contribution to total landing work. And the knee is like 60 or 80%. And the hip and the ankle don't do very much. So in this movement, the knee for sure is involved, and there is lots of strength, like on the ACL and on the knee extensors. But we don't pick that up just by measuring the distance you jumped. So if we can measure more appropriately the way that you landed or something like that, or maybe we can throw you. You know, if we throw you a meter, then we know exactly what's going on in your knee, but we can't really do that. So that's the main reason why it's just in practical settings, it doesn't seem to be really working in our, yeah, thank you very much. Great questions. I'm sorry.
So the ACL is a passive structure.
Right.
With all this causing is powered by nothing. Is it really a muscle deficit that you're measuring?
Is it really a muscle depth? Can you be
Well, why should there be a difference in performance? Is it because those muscles have weakened with disuse while during recovery?
Yeah, so the main reasons that we're seeing these significant deficits following these ACL reconstructions are that, you know, number one, we've disrupted the proprioceptive ability of this knee to sort of coordinate itself. But then in the process of opening up the knee and harvesting graft tissues from some of these active contributions, we have certainly almost more so disrupted the muscle than the joint itself. And so a lot of surgeons will actually say, you know, once I fix the ACL, you know, that's fine. Now you have to recover from this part. And this is really where the recovery happens. Because in theory, the knee is stable. And so the recovery sort of happens actually more kind of on this side of things. And so we see actually in patients that get cadaver grafts, where so you can get like a donor tissue from a cadaver, at least in the early stages of the rehabilitation, a lot of the strength and the pain that we see in these kinds of grafts, it doesn't really exist to the same extent because we haven't disrupted all these tissues.
Brett, and then Mike.
Nathan, when you look at the asymmetries in these athletes, the differences that you find in your parameters, they could be due to deficits in muscle strength.
For sure,
It could also be due to them guarding
for sure.
the leg. How do you distinguish between the two, and do you care to?
So I would probably argue that we don't care to, especially considering the fact that the main problem with the way we test these athletes is we're so far removed from their field of play and from the forces and the environments that they're putting themselves into, which are we consider dangerous, which is sport. And so if they are feeling guarded and they are weak and they can't perform in this kind of very sterile, safe environment, then we can only imagine how they will sort of perform when they can't pay attention and they are unable to anticipate. And so if they don't have the strength and the kind of wherewithal to perform in this very sterile environment, then we can imagine how they would perform in a less sterile environment.
And then just another question is, I guess you have deficits in strength, your ability to generate much force as possible. I presume you could also have deficits in your ability to sustain a muscle contraction. And this protocol that you have is kind of requires both. You have this sort of like this impulsive jumping protocol, but it's repetitive. And so you are holding this sort of sustained muscle contraction. Do you have a sense of, after an ACL injury, what is affected more? Sort of your peak ability to generate strength or your ability to hold or maintain a contraction.
Right, so I'm gonna assume by hold a contraction, you mean exhibit multiple repeated contractions,
Yeah,
because they're kind of short contractions.
they're very short contractions. Yeah, I mean, it's not just like one constant contraction, but I assume that you kind of fatigue a little bit over time.
Yeah, for sure. So, one thing that I'm interested in that I haven't looked a lot in is understanding the sort of hop variability, which would sort of kind of address that a little bit. And I actually
Have you looked at how those parameters change over the course of the test?
yeah, so like this hop height versus that hop height versus the next hop height, like,
Yeah.
like hop height for each
Yeah.
hop.
Yeah.
So I have, this is gonna be kind of some incomplete data, but I kind of expected someone to ask me questions sort of like that. So I have. So on the y-axis here is our coefficient of variation of a reactive strength index. And then the x-axis is your reactive strength index. So more variability in your hop-to-hop performance, and then better performance. And so if we ignore the hop fast condition, we can see that generally people that are hopping worse have an increase in their variability over the course of the entire hopping
The
test.
reactive strength index there on the x-axis would be the mean one. that
Would be,
we calculate?
yeah, so mean of the test. Yeah, so mean across the 15 hops. And then this would be the variability across the 15 hops. And so we can see that, it's actually a pretty strong relationship. And this is from a while ago, so this isn't complete data set, and this is only the uninjured and injured limbs. But this is sort of the pattern that we are kind of starting to see. And so I'm sure that there is an optimal, like you'll notice that no one reaches zero. It'd be kind of weird to hop perfectly the same every single time. And so I'm sure that there's sort of an optimal variability that we kind of want in our human movement. Does this kind of help answer?
No, but it's interesting.
It's interesting also. Yeah.
It's a little bit different. It's interesting. Thanks.
Yeah, no, I just realized it's a little different, but I thought you found it interesting.
When you're talking about with Dr. Bertram's question about how they recover more from, like if you take the graph from the lieutenant, how much of these decrements are based on how you fix the injury rather than the injury itself?
So, if you don't fix the injury, you can also return to sport, is how I would phrase that. So, like once you kind of move past the trauma of the original ACL injury and the swelling's gone down and you've had some time, you're kind of back to moving around. Many athletes can sort of return to sports. And if you're not an athlete, you're just kind of interested in returning to your general life, you should be able to kind of recover from this injury. Other than the fact that you now have this slight instability in the knee. So a lot of the deficits that we see are actually, especially early on after the surgery, are stemming from the fact that we are sort of opening up this person, tearing out some tendons, wrapping up and then shoving them back in the knee. And that whole sort of event is almost more traumatic than the injury itself. And so we're trying to solve the stability piece. But if you, for whatever reason, don't care about the stability of the knee, but you care more about the strength and your kind of long-term and your longevity in strength and performance, then you might opt to not get the surgery at all. You sort of have to play a bit of what is it that I want to actually optimize for?
Bill and then you.
I think going back to Mike, so how would the results differ depending on what repair they got, whether it was patella tendon or hamstring tendon? Would that change the results that you're showing here? Like if you have groups of athletes based on how they got the repair done?
Great question. So, I mean, short answer, I don't know. So we try to only include the anterior chain group to keep the entire group as homogeneous as possible, because we do see differences, especially in the bone, patellar bone and the hamstring graft, like those kind of result in some different sort of movement patterns, especially when it comes to knee extension strength. So what we're really interested in is understanding how does knee extension strength sort of play into kind of, but we know that our hamstring graft group tend to not have the same knee extension deficits as the anterior chain group, as you can kind of imagine. So I haven't done any like kind of group-based analysis on this yet. I would imagine that I wouldn't see anything based on the data that we have here. And I can't recall anything that is super compelling comparing the quadriceps and the patellar tendon grafts that would make me think otherwise based on the data I have here.
A little bit related to that question, I remember a seminar quite a while ago, I think it was a couple of years ago, and they were showing differences in which graft people got for reconstruction. And maybe I'm remembering wrong, but the setting tendinosis one seemed to be the best in terms of regaining or improving the deficits that you feel after the reconstruction. And I was wondering, is it based on some specific data or objective reason why someone would get a certain graft, or is it just random because of that?
So the number one thing that dictates what graft you get is what graft the surgeon you're working with is most comfortable, as you can imagine. So if your surgeon only ever does hamstring grafts, you don't want them doing their first ever quad tendon graft on you necessarily. So that's usually when I'm, especially in the clinical setting, speaking with patients, it's like whatever the surgeon wants to do and they're most comfortable with, we're probably going to go with that. I also will tell people that once we're in this situation, I mean, they're all bad outcomes, you know, like it's like none of this is fun. And so they're all kind of bad outcomes. You sort of have to pick your poison. There is an idea that certain sports might, you might prefer to select one graft or the other. So here we get a lot of skiers. A lot of skiers end up getting the semitendinosus graft, which is probably part of what you were describing, because they spend essentially the entire time going down the hill in a flexity posture. So it might kind of depend a little bit on the sport that you play and the sort of deficits that you're willing to accept for that sport. But generally, it's, especially again in terms of general public access to ACL reconstruction surgeons, whatever the surgeon is most comfortable with is usually what you get.
Jim had a question, and then the online one.
Is it common practice to use this protocol, but only when someone is injured, just to see whether they might have a deficit or something like that?
Would you?
So like all the jumping tests and stuff, show, like, do they only do that when someone's injured, just to see if there's like a deficit or something, or they? So I was thinking, like, if it were common practice, you could change your protocol a little bit. Like you have to switch from frequent to Bayesian mixed effects model, which is a nightmare. But if you use someone as their own baseline, because the concept of type 1 error doesn't apply to that paradigm, you could actually track their recovery over time to see if they're like compared with their own baseline once the distribution posteriorly verges on that. You can say like you've actually you've returned to your pre-injury state. So you might be able to use that same approach to track the recovery back to their own baseline as opposed to some population.
Yeah, so understanding or coming up with benchmarks of like where should we get you is its own sort of topic in and of itself. And for sure, using someone's own baseline seems like the most reasonable approach. The issue with that is that if I tear my ACL, then I was clearly at risk in some way, unless it was like a freak injury, maybe. Then I was at risk. So maybe my own baseline isn't actually where I want to get back to. So that's kind of one sort of counterpoint to that. But to the essence of your question is, do we do this for uninjured athletes? Yes, very much so.
You could use like a population or that's a people baseline to compare them with and still watch them track towards that, just to see like is recovery on track, are they not shifting from where they were, because you can keep this rapidly over time.
Yeah. So
concept of like type 1 error doesn't apply.
So I will introduce you to Zach in the back, who is doing a lot of work on understanding how we can use machine-based learning to essentially come up with like kind of a population-based benchmark for individuals that are, either in the same sport or that look kind of like you. And we're trying to address that as well. But the idea of using a Bayesian-based approach, and then you can kind of like track their sort of return back to this baseline over time is an interesting. Thank you.
All right, Robert, go ahead.
Thanks, Nathan. When you have pain in the knee, even a subconscious pain in the knee, you can get neural inhibition of the activation of the muscles, and so you can't stimulate them hard enough. If you put a brace on the knee, as we often do, and you get a decrease in pain and an increase in confidence, that could lead to a removal of some of the neural inhibition that's been blocking the pathways and could lead to an increase in performance. And it seems you're in a perfect position to put a brace on one of these knees, see if the performance goes up, which may be, I can't see a mechanical reason for it, more a neural removal of the neural inhibitions. What do you think of that, and have you done it?
I think that's a great idea. I have not done it. So we consciously chose to not test these athletes in their braces. As you can imagine, most of the people that participate in this study have been prescribed a brace at some point. And so we consciously chose to not include the brace in the testing, just to sort of minimize the number of different confounding variables. People have different braces fit differently. But I completely agree with the notion that a brace increases confidence, might decrease pain improves, neuromuscular output, which would, potentially lead to increased performance in a test like this. I completely agree with that wholeheartedly. And so that would be an interesting thing. I'm not aware, I'm sure people have done that. I'm not aware of studies that have looked at that. But that's a great idea. And we see that also a lot in arthritis of the knee, that a lot of these braces, especially these like spring-loaded braces that kind of actually offload some of the demand placed on the knee extensors, dramatically reduce pain and subjects begin to get stronger, even just by wearing this brace that actually kind of reduces the amount of force that they need to create over a very short period of time.
Yeah, fascinating. Thank you, Jay.
Thank you very much.
Why did you choose to look at the integral of the EMG and not an average or peak? Because there's like huge differences like contact time, sliding time. What's the rationale behind that?
So the rationale behind that was that is sort of the approach that other people have used. I do agree though, because the differences in contact time could actually account for a lot of the differences in the integral that we're seeing. And so I was actually thinking about that very recently. I was kind of going back through a lot of this. I was like, oh, this could just be because of the time difference. And so, yes, I acknowledge that that's probably a limitation. But truly did that because that's what other people are doing. So I'm just kind of going through the motions a little bit, honestly, in retrospect. So I will definitely kind of look at mean total activation over these time periods, because I think that might be more interesting.
And second question, more like about the cues you're giving for the high jumps. You can see they're using the other leg to help them jump higher. Do you have any instructions for that?
So I realized after embarking on this that doing research where you give people instructions and you have to sort of let them interpret your instructions a little bit, but you can't be like so hands-on, like, no, I want you to do it exactly like this, because we want this to be a little bit real world. So I did do my best to kind of give them the instructions. We practiced a little bit. We talked about the difference between the two instructions. I did my best to make sure people were not swinging the leg. Like I said, like we want to keep the knee in front of this hip as much as we can, and not sort of swing it. But I wasn't removing certain hops or removing trials if the, you know, contralateral hip flexion was reaching certain velocities or something like that. So like we talked about what we were trying to do. And people generally, you know, I made sure, like, do you understand the conceptual differences between these cues? Everyone gave me a thumbs up, and then we kind of move forward. So I tried to account for that a little bit, but there was no kind of post hoc managing that. But I did think about that also, yeah, thank you.
So you talked about how an ACL reconstruction kind of affects two aspects of the individual, and it's like the stability and then the strength. So I would kind of argue that at least with this test and the measurements you pulled out of it, that you don't really measure stability, you measure like muscle strength. So I'm just kind of curious, like, how would you measure stability at, like, you know, in a test right after this one, and kind of how do you know when it returns to normal?
Right, so I guess we should define stability.
Right.
And so when I'm referring to stability, I think I'm referring to like the total excursion capacity of the tibia relative to the femur itself. And so there's a fun little instrument. So the best test that we have to measure this is a clinical test where the person's lying down, you just kind of Walkman the tibia forward. And so you can, there's a cool little device that will measure the distance traveled. And so that would be like the best sort of like assessment of stability of kind of passive though, right? Passive stability. So you're just an active stability of the knee,
I guess. Yeah, because that, like, playing a sport, you know, getting back on the field, you'd want to have active stability or more control. I don't know.
Yeah, right. So,
I feel like this test is very, you know, single plane,
very much.
and real movement is more, has more planes.
Has more planes, yeah. So this is not the end all be all of tests. And in fact, I like early on, I said, like, these are many different ways that we test people. And you would probably be doing yourself a favor by, you know, throwing many tests at an individual to, you know, essentially look for reasons why they're not performing well. Because you're constantly looking for what's a trainable deficit that we can improve upon, sort of in all athletes, injured or not. And so there are definitely more like plant, cut, turn kind of tests that rely more on kinematics, and like measuring hip internal rotation, knee valgus, knee flexion, type moments. And so that would probably be more akin to kind of what you're talking about. With regards to this test, you could look at their sort of excursion kind of around the plate, as sort of just like an easy little add-on to this, like how, like, it'd be most efficient to jump straight up and down. So the more you're moving around, you're being a little bit less efficient. So that's an easy thing that we could probably begin to sort of tease out to see if there's just more interesting things about a repeated hop test that we can look at. But regarding the like true active stability of a knee in sport like maneuvers, you have to be doing like, you know, a large space kinematics, planting, cutting, maneuvering, a lot of the kind of work that Caddy Passman's group is working on.
A follow up to that, how would you implement that in like a basic PT clinic setting, like that doesn't have access to motion capture and like kinematics stuff?
So there's a lot of new markerless mocap systems that are becoming more available. You know, all you need is 2 iPhones and you can, you know, get reasonably good data with a lot of this as long as your sort of protocols are in place. And so that would be that it's becoming increasingly available. Just like force plates were kind of like, are still becoming increasingly available, they're kind of like, their availability really increased somewhere in the last 5 or 6 years. So people are more interested in these kinds of tests, but as markerless mocap becomes more available, I think we'll get more interested in, you know, how much can we learn what a person does with an iPhone? It's probably a lot. Good question.
While we're waiting for questions, going on to Adam's question, are there parts of this test that can tell you a little bit about stability? Like if you already are dividing things into landing and propulsion, and I would assume like some parts of those landing and certain metrics above that would maybe give you a hint at the stability, or am I thinking in the wrong direction?
Yeah, I'm not totally sure where you're getting that. So we can look at stiffness about an individual joint, or the stiffness in the kind of entire person. And the way that, at least in my observation of people, generally, like often we might think of stiffness as being either a good thing or a bad thing. These athletes that are weaker and that are not getting as far, they're not letting their knee bend as much, and so they're actually exhibiting a more stiff movement style, which might actually be interpreted as more stable. But because the task demands them to jump high, they need to be a little bit more sort of compliant to allow for like some compression to occur so that you can actually then push up. I'm not sure how you would assess like true knee stability actively in something like this with the fidelity that you would want to. So I mean, if you had little IMUs that sample at a crazy high frequency, maybe you could start to pick up like true like shifting and rotation at the level of the knee joint. But you know, like at 200 hertz, I don't think you'll pick that up.
And then one more question for you. You were trying to see the differences between your injured, uninjured, and then your controlled.
Yes.
You didn't find any differences there. Do you think that is because this was a bilateral jump and?
Or these are unilateral jumps.
I thought the test you were showing they were jumping with.
No, that was one person hopping on both of his one legs.
Okay.
Yeah.
That makes sense. Any questions?
So I've got 2 scenarios. Same question though. So would you expect a different movement strategy if they were to jump off of, let's say, a force plate into a foam pit where they don't have to worry about deceleration on the way down? And then second scenario would be same concept except on, say, like a playing surface. So somebody that plays on turf to jump repeatedly on turf, because that would absorb some of that like eccentric loading. I guess
Yes. So like if I jump up as high as I can, and someone quickly replaces the surface underneath me with a foam pit, would I jump differently than if I knew I was landing on a hard ground?
Yeah.
Would I jump differently? So I think the pattern that you would see in that kind of propulsive phase, I don't think that would change. I think the repeated hopping on the softer surface would influence sort of the total stiffness of the entire system being the person and the surface. And so there have been studies where they look at how like surface stiffness changes how people would do a test like this. I can't remember the results, but yes, it does change. Because you aren't developing the force as quickly because the thing you're trying to push into is kind of simultaneously compressing with you. So generally, if I were to make an assumption, it's that, ground contact times would be longer, probably peak forces would be either later or like kind of non-existent, and there'd be this kind of slow deceleration phase. But I don't think that the perceived risk of landing on a firm surface would change the way a person jumps, especially if you're telling them to jump as high as they can. I think that they will do that regardless of the firmness of the surface, unless there's like a pebble in their shoe, right? And there's something like truly about the firmness of the surface that would actually be sort of deleterious.
Hands going up, so we'll thank him there.